Bismillah. Bismillahir Rahmanir Rahim. The quote for the day is: If you are grateful, I will certainly give you more. This is an ayah from Surah Ibrahim. The topic for today's presentation is influenza. I am Dr. Ayesha Amin, PGR of FCPS Community Medicine at Institute of Public Health Lahore, and I will be presenting this under the kind supervision of my supervisor, Professor Dr. Saira Afzal, who is the Dean of IPH Lahore. So the learning outlines for today's presentation is introduction of influenza virus, epidemiological determinants of influenza virus, prevention and treatment, burden of disease, recent advances, and multiple choice questions. Learning objectives. At the end of this presentation, the participant would be able to describe the epidemiological triad and the prevention aspect of this infection, and they will be able to understand the factors that contribute to its spread, their prevention, and to be able to answer the MCQs. Introduction. Influenza, which is commonly known as the flu, it is an acute, contagious viral respiratory disease which is caused by influenza virus, whether A, B, and C. It causes annual seasonal epidemics and it can lead to global pandemics as well. It is a significant public health concern due to high transmissibility, morbidity, and occasional severe complications. It affects all age groups, but severe disease can occur in young children, elderly, pregnant women, and immunocompromised individuals. The epidemiological triad of the influenza virus agent. The influenza virus belongs to the Orthomyxoviridae family. They are enveloped, single-stranded, negative-sense RNA viruses. They are classified into three main types, which are affecting human: A, influenza virus A, B, C, and D, which infects cattle. So coming to the brief detail of influenza viruses, the type A virus, it causes seasonal epidemics and pandemics. It infects humans, birds, pigs, horses, seals, which are the large reservoirs for the virus. The major human disease causing subtypes of influenza type A virus is H1N1, which causes swine flu pandemics, H3N2, which cause seasonal pandemics, seasonal epidemics, and H5N1, which causes bird flu. The type A virus, it goes antigenic shift as well as antigenic drift. The antigenic shift, as we all know, is a uh, sudden change, while antigenic drift is a minor change. And the antigenic shift, it is basically responsible for causing pandemics, while the antigenic drift, which is a minor and gradual change, it is the cause of epidemics. Type B, the influenza type B virus is almost exclusively infects human. There are no major animal reservoirs. It does not cause pandemics. It only causes seasonal outbreaks. It only undergoes antigenic drift, but it is slower than type A. The type C influenza virus, it causes mild diseases in human, mostly in children. It is not associated with epidemics. The type D influenza virus, it infects cattle and pigs, and it is not known to cause disease in human. The host factors which are responsible for influenza virus infection are age. The high risk individuals are again the extremes of age: children less than 5 years and elderlies over 65 years of age, pregnancy, immunocompromised states, patient taking steroids, or any person with autoimmune diseases, chronic diseases such as asthma, chronic obstructive pulmonary diseases, diabetes, and heart diseases. Unvaccinated individuals are more susceptible for getting infection. Close contact groups, that is school children, healthcare workers, military recruits, and poor immunity or malnutrition also increases the severity of influenza infection. The environmental factors is the seasonality. The influenza infection, it peaks in winter. Cold, dry air favors the transmission. Overcrowding, that is school, hospitals, public transport, camps. Poor ventilation and indoor crowding increase spread. Global travel facilitate rapid worldwide transmission, and low socioeconomic condition, which leads to poor access to healthcare and vaccination. They all contribute to the influenza infection. The source of infection, infected human are the primary source of infection for influenza A and B virus. The respiratory secretions, mainly nasal discharge, saliva, sputum, they contain high viral load. Symptomatic carrier can shed virus and spread infection. Animal reservoir for influenza A, birds, wild waterfowl, major reservoir, pigs, which are the intermediate host allowing ressortment. The incubation period and the infectivity. The incubation period of the influenza virus ranges from 1 to 4 days with an average of 2 days. The infectivity period is 1 day before the symptoms onset, up to 5 to 7 days after the onset. That is longer in children and immunocompromised individuals. Transmission. The influenza virus has following modes of transmission: droplet transmission, coughing, sneezing, talking, contains large respiratory droplets. The main route is spread within 1 meter distance. Aerosol transmission, small airborne particles in poorly ventilated, crowded indoor spaces. Contact transmission, touching contaminated surfaces, fomites, and then touching nose, eyes, or mouth. Close contact transmission, school, daycare centers, hospitals, and public transport. And zoonotic transmission, close contact with infected birds or pigs, mainly for influenza A strains, which leads to swine flu and bird flu. uh, Coming to the pathogenesis of influenza virus, the virus, it enters the respiratory tracts and binds to the sialic acid receptors. It then replicates in the respiratory epithelial cell, causing cell damage and impaired mucociliary clearance. There is release of cytokine which produce systemic symptoms of fever and myalgia. There is local inflammation which leads to cough and sore throat. It damages the epithelium and increases the risk of secondary bacterial pneumonia, and the severity of the infection depends upon the viral virulence, host immunity, and comorbidities. Clinical feature. The influenza infection shows a range of symptoms from sudden onset of fever. There can be chills and rigors, headache, myalgia, marked fatigue and malaise, dry cough, sore throat, nasal congestion. There can be GI symptoms which are vomiting and diarrhea, flushed face, and mild lymphadenopathy. Complications. The complications of influenza virus can be primary influenza viral pneumonia, secondary bacterial pneumonia, croup, which is tracheolaryngobronchitis, myositis, Ray's syndrome, and myocarditis and encephalitis, which is rare. Coming to the diagnosis of influenza virus is basically clinical diagnosis. It is based on the sudden onset of fever, cough, sore throat, myalgia during influenza season. Useful. The testing is useful when testing is not available or in outbreaks. The clinical diagnosis is mainly useful when the testing facilities are not available. The laboratory diagnosis of influenza consists of following tests. The first of all is rapid influenza diagnostic test, which detects the viral antigen and it gives the result in 15 to 30 minutes, and it has moderate sensitivity, but it has high specificity. The reverse transcriptase polymerase chain reaction, that is RT-PCR. It is the gold standard test for influenza virus. It detects the viral RNA. It is highly sensitive and specific, and it differentiates between influenza A and B subtypes, and also between its subtypes that are H1N1, H3N2. The viral culture, it confirms the infection, but again, the culture takes time, usually 3 to 10 days, and it is mainly for use for research and surveillance. The immunofluorescence test that detects viral antigen in respiratory samples, and it has moderate sensitivity. Specimen collection. The preferred samples which are taken for detection of the influenza virus are basically the nasopharyngeal swab, while in certain cases, throat swab, nasal aspirate, or bronchoalveolar lavage can also be taken. Coming to the prevention of influenza virus, the primary prevention is annual influenza vaccination for all greater than 6 months of age, health education on hand hygiene, cough etiquette, use of mask in crowded high risk setting, improve ventilation and reduce overcrowding, avoid contact with sick individuals, sanitation and surface disinfection, nutritional support and immunity strengthening, travel advisories during outbreaks, and animal handling precautions for zoonotic strains. So, there are basically three W's to protect yourself and other this season. The first is wash your hands, wear your mask, and watch your distance to halt the spread of influenza infection. And also, the important is get your flu shot. For the specific protection, the immunization for influenza infection is also available. The influenza or flu vaccines, which are often called as flu shots, are the vaccines that protect against the four influenza viruses. Most flu vaccines are flu shots, which are given with the needle, usually in the arm, but there is also a nasal spray flu vaccine available. The CDC recommends annual influenza vaccination coverage for everyone aged 6 months or older. Vaccination is especially important for people at high risk of influenza complications. So there are certain type of vaccines which are available. First of all is influenza inactivated subunit vaccine, which is given as intramuscular or intradermal. Then there is a live attenuated vaccine, which is basically comes in the form of an intranasal vaccination. Then there are trivalent vaccines which contain three inactivated viruses. Type A, which is H1N1, type A, type H3N2, and the other is type B. The quadrivalent influenza vaccines are also available, which were introduced in 2013 and 2014. They contain the same antigens as trivalent vaccine, with the exception that the quadrivalent vaccine contained two type B strains. Vaccine viruses are grown in the chicken eggs, and the final products contain residual egg proteins. The vaccine is available in both pediatric, the dose is 0.25 ml, and for adult, it is 0.5 ml dose formulation. The vaccination schedule for influenza is age group for children from 6 to 35 months of age. The dose of the vaccine is 0.25 ml, and it is given two times. For children 3 to 8 years, the dose is 0.5 ml, and again it is given as in the form of two doses, while the children who are greater than 9 years, the dose is 0.5 ml, and it is usually given as a single shot. So why should we get an yearly flu vaccine? The flu vaccines are constantly changing. Flu vaccines may be updated from one season to the next to protect against the most recent and most commonly circulating viruses. September and October are generally considered good times to get vaccinated. Vaccination in July and August is not recommended for most individuals but can be considered for some groups. While ideally it is recommended to get vaccinated by the end of October, it is important to know that the vaccination after October can still provide protection during the peak of flu season. Annual vaccination is recommended is that the person's immune protection from vaccination declines over time, and annual vaccination is needed for optimal protection. So you need to get your flu shots every year. There are certain contraindications for the use of vaccine. If the person has severe allergy to chicken eggs, severe reaction to previous vaccination, the patient developed GBS within 6 weeks after getting vaccination, or children less than 6 months of age, they should not be given the flu vaccine. Secondary prevention, which aims for the early diagnosis and treatment. So the early diagnosis is done usually by using rapid test for or the reverse transcriptase polymerase chain reaction, which is the gold standard, screening of high risk contacts during outbreaks, prompt antiviral therapy, which include oseltamivir and zanamivir within 48 hours, isolation of symptomatic individuals, monitoring for complications, for example, pneumonia, contact tracing during outbreaks, and chemoprophylaxis for exposed high-risk individuals. Tertiary prevention for management of complications, which can be bacterial pneumonia, exacerbation of asthma or chronic obstructive pulmonary diseases, dehydration or respiratory failure, supportive care, which include oxygen, fluids, hospitalization if needed, rehabilitation for severe cases, prevent worsening of chronic disease, and strengthen follow-up for elderly and immunocompromised patients. Coming to the epidemiology of influenza virus, the global burden, there are around a billion cases of influenza annually, including 3 to 5 million cases of severe illness. It causes 2,90,000 to 6,50,000 respiratory deaths annually. 99% of death in children under 5 years of age with influenza-related lower respiratory tract infections are in developing countries. So this diagram shows that globally there are up to 30% of all the children which are affected and up to 10% of adults which are affected. This diagram shows the flu pandemics which have been occurring over the year. The first pandemic was observed in 1918, which is known as Spanish flu pandemics, will lead to 50 million deaths. Then there were, and again, a pandemic in 1957, which was Asian flu pandemic, which caused 1 million death. Then in 1968, there was a Hong Kong pandemic, again, which led to 1 million death. In 2002, there was severe acute respiratory syndrome epidemic, which leads to 774 deaths. Then there was an H1N1 pandemic, which leads to a large number of deaths, around 2,84,000 deaths in 2009. And again in 2019, we all have observed the COVID-19 pandemic, which in April 20 causes almost 67,594 deaths. The burden in Pakistan, the surveillance systems are not nationwide or comprehensive, so the data come from sentinel sites not covering all regions. Because of the underreporting and the limited lab confirmation, many influenza-like illnesses are not confirmed, so the real incidence and mortality is hard to gauge. Khyber Pakhtunkhwa, over a 6-month period, May to October 2023, reported more than 130,000 people with influenza-like illness at public sector health facilities. Because the infection is usually seasonal, so most of the cases they goes unreported, and the lab confirmation is usually not done. This bar chart is basically showing the monthly share of influenza tests that were positive, and these are the only cases which were reported. So we can say that in Southern Hemisphere, there was almost 8.9% of the cases which were tested and they were positive in a month at October 1, 2025, while in Pakistan, there were only 3.6% of the cases that were shown to be positive via lab. So this is usually this is a very small number, as we all know that influenza is very common, and again the same reason is there, because reporting is not done and lab confirmation is hardly done. This map is showing that the national policy on flu vaccination for older people according to 2020. We can see that the areas which are shown with the blue color, we can see that it shows that there is a vaccine recommendation policy is available, while in the orange color it shows that their recommendation is not done, and the gray shaded areas shows that there is no data about these countries. So unfortunately, Pakistan is in this gray shaded area, which shows that there is no data available for the vaccination of older people. Recent updates. So this is an article which was published in 2023, and it states that an intranasal multivalent epitope-based nanoparticle vaccine confirmed broad protection against divergent influenza virus. So the development of a universal influenza vaccine to control public health threat from circulating and emerging influenza virus is highly desirable. In this study, they report an intranasal multivalent epitope-based nanoparticle vaccine with broad protection against divergent influenza A and B viruses. 3 highly conserved epitope consist of alpha helix of heme agglutinin H and the ectodomain of matrix protein of neuraminidase are presented on a self-assembling recombinant human heavy chain ferritin cage to generate the HMNF nanoparticle. Intranasal immunization of mice with HMNF mobilized potent immune response. Vaccination with HMNF conferred full protection against lethal challenge with divergent influenza A and B virus. The broad protection of HMNF nanoparticles could be attributed to the synergist function of the antibodies and T cells. Moreover, the induced immune response are long-lasting and protection is maintained 6 months after vaccination. So the study concluded the HMNF nanoparticle they can serve as a promising candidate for a universal influenza vaccine. Coming to the multiple choice questions, the first MCQ is during an influenza outbreak in a school, multiple children develop symptoms. Which environmental factor most contribute to the rapid transmission? A. Outdoor gathering. B. UV sunlight exposure. C. Poor classroom ventilation. D. High humidity. E. Low student density.
C.
Yes, C is the right answer. A 50-year-old man received influenza vaccine but still developed influenza. Which explanation is most likely? A. Antigenic drift of circulating virus. Vaccine is completely ineffective. Antigenic shift with vaccine strain. D. Vaccine contain live virus. E. He was vaccinated too early in childhood.
C. A.
Yes, the right answer is A, antigenic drift of circulating virus, because we know that antigenic drift is a small gradual change and it usually causes epidemics, while the antigenic shift is a sudden change and it causes pandemics mostly. The third MCQ is a pregnant woman in second trimester presents during a community outbreak of influenza. From a public health perspective, most appropriate action is A. Delay vaccination until after delivery. B. Advise isolation for 30 days. C. Vaccinate immediately with the inactivated influenza vaccine. D. Perform chest CT screening. E. Start oseltamivir prophylaxis routinely.
E. D.
Right answer is C. Vaccinate immediately with inactivated influenza vaccine. 4. 4. During winter, a sudden rise in absenteeism from school is reported. Which public health action should be prioritized first? A. Close all school for 4 weeks. B. Begin influenza vaccination campaign inside school immediately. C. Start empiric antiviral therapy for all students. D. Mass serological testing. E. Conduct influenza-like illness case definition screening and report to surveillance unit.
B.
Uh, the,
B.
the right answer is E. Conduct ILI case definition screening and report to surveillance unit. The fifth MCQ is during an outbreak, the lab confirmed influenza H3N2 strain. What does this imply for public health response? A. No action needed as H3N2 is mild. Expect higher hospitalization rate in elderly. Close all airports. D. Vaccinate persons are not protected. E. Antivirals are ineffective.
D.
The right answer is B. Expect higher hospitalization rate because there is an outbreak and there are the sixth MCQ is a public health officer wants to reduce transmission in schools. Which strategy is most effective? A. Disinfection of desk daily. B. Promoting respiratory hygiene and staying home when ill. C. Providing hand sanitizer only at entrance. D. Forcing vaccination of all students. E. Screening all students with PCR weekly.
B. B.
Yes, B is the right answer. The seventh MCQ is H5N1 is the highly pathogenic and contagious causative agent for the H5N1 flu, that is swine flu. Which of the following is the source of H5N1 infection in human? A. Birds. B. Pigs. C. Ferrets. D. Cattle. E. Dogs.
A. B.
Yes, H5N1, sorry, H5N1 causes bird flu. So the birds. The right answer is birds. That is A. Influenza virus spread when people with flu, cough, sneeze, or talk and sending droplets with virus into the air. Which of the following statement is not correct about the measures of the influenza virus? A. Washing hands more often helps. B, a sick person with flu should stay isolated at least for 24 hours. The over-the-counter antiviral drugs are available for the influenza virus. D, live attenuated and inactivated viruses both are used for vaccination. E, detect flu virus by respiratory specimen.
D.
D. The right answer is over-the-counter antiviral drugs are available for the influenza virus. The MCQ states that which statement is not correct. So the antiviral drugs, they should not be used as an over-the-counter agents. Which public health measure is most appropriate for preventing influenza outbreaks in hospitals? A, patient isolation only. B, universal staff masking during influenza season. C, daily PCR testing for all staff. D, administering live attenuated vaccine to the immunocompromised patient. E, closing outpatient departments.
B. B.
Yes, B is the right answer. So the last MCQ is, what is the best time of the year for a person to be vaccinated against influenza? A, vaccination by the end of October. B, in summer before the next peak flu season. C, flu symptoms develop. D, anytime it makes no difference. E, vaccination in July and August.
A.
Yes, the recommended is between September and October. So vaccination by the end of the October is the right answer. This is the key to MCQs. And this is the channel of Institute of Public Health where the recording of this presentation will be uploaded. And thank you for your attention.